Gonna wait a few more minutes while people sign in, and then we'll get started. Okay, we might start. Okay, hello everyone. I hope you've all been well. Thank you for joining us today for our very first session of this new clinical webinar series, which has been initiated by the ASBMR Early Stage Investigator Subcommittee. We know that clinical training as well as conferences have been affected by the COVID-19 pandemic, and we hope that this clinical series will be a useful educational resource. So we have an amazing panel of speakers who'll be talking to us today about diabetes and bone health. I'd like to start with a few housekeeping rules. I want to let you know that our session today will be divided into two halves. We will have one panel of speakers speak in each of the halves, and then in each session you will have 10 to 15 minutes at the end for a question and answer discussion session. Throughout the duration of the presentation, you may submit any questions or comments through the Q&A function of your Zoom, or alternatively, during the Q&A part of the session, you may use the raise your hand function to ask questions. So first, I would have the pleasure of introducing our first set of speakers from the University of California, San Francisco. We have the privilege of hearing from Dr. Ann Schafer and Dr. Tiffany Kim. Dr. Schafer is Associate Professor of Medicine and Epidemiology and Biostatistics at UCSF and is also Chief of Endocrinology and Metabolism at the San Francisco VA Healthcare System. Dr. Kim is Assistant Professor of Medicine at UCSF and Staff Physician at San Francisco VA Healthcare System. And today our session will be moderated by Dr. Elizabeth Winter from Leiden University in the Netherlands. Dr. Schafer and Dr. Kim, thank you so much for joining us. I'd like to welcome you to share your slides and begin your presentation.
Okay, great. Thank you so much. I'd like to thank the ASBMR Early Stage Investigator Committee for inviting us to speak today. We're excited to present our case and take this opportunity to talk about diabetes and skeletal health. All right, here are our disclosures. For our case, this is a 68-year-old Caucasian man with type 2 diabetes, complicated by peripheral neuropathy and nephropathy, chronic kidney disease stage 3, peripheral vascular disease, hyperlipidemia, who presents with a left hip fracture. He tripped in the park and fell on asphalt, so he had a ground level fall. And he has a history of a wrist fracture in 2001, for which he was treated with a Alendronate for 3 years. For his type 2 diabetes, he was diagnosed 8 years ago. It was GAD antibody negative, and he has had poor control in the past with hemoglobin A1C values as high as 14.5%. For his diabetes, he was treated with metformin and glipizide for 6 years, and then basal bolus insulin for the past 2 years. For surgical history, he's had angioplasty and stenting. For his medications, he takes Glargine 8 units daily, Aspart 3 units with meals, cholecalciferol 2,000 units daily, pregabalin, and atorvastatin. He has no family history of hip fracture or osteoporosis. He currently smokes 1 pack a day for the last 20 years. He has a history of heavy alcohol use, although sober, for the past 10 years. His review of systems is otherwise negative. On physical exam, he weighs 155 pounds. His BMI is 22. His left leg is shortened, externally rotated, and tender to palpation, and he has no spinal tenderness upon palpation. These are his lab results. He has normal calcium, albumin, and phosphorus, elevated creatinine, which is consistent with his baseline values, creatinine 2.0, with an estimated GFR of 35. His 25 vitamin D levels, 38.5. He has a normal PTH value, which we were expecting it might actually be a little higher given his CKD, and his hemoglobin A1C is 7.4%. Here is his imaging of his left hip. At the time of admission, he had a subcapital left femoral neck fracture. I've listed his DEXA results here. In 2001, the lumbar spine T-score, minus 0.4, femoral neck, minus 1.4, total hip, minus 1.3. You can see with 3 years of alendronate, the T-scores did improve, and the most recent DEXA scan in 2014 shows at the lumbar T-spine T-score minus 0.1, femoral neck minus 1.6, and total hip minus 1.2. So based on the last DEXA, he has low bone mass, but not necessarily osteoporotic range bone mineral density. He also had a fairly recent spine film, a thoracic spine x-ray from December, which showed a vertebra plana compression deformity of the T8 vertebra. And you can see here it's very compressed and wedge-like. And there was also a minimal anterior wedge compression deformity of T4. We thought this case was a great opportunity to discuss questions about diabetic bone disease. And so in the next several slides, I'll address these following questions. Is type 2 diabetes a risk factor for fracture? Can estimates of fracture risk be adjusted for type 2 diabetes? And are osteoporosis medications effective in people with type 2 diabetes? All right, so what are the fracture risks in type 2 diabetes? This meta-analysis from 2016 looks at hip fracture. It looked at 12 studies, and you can see overall there is an increased risk, about 34%. While this is a modest increase, type 2 diabetes is so prevalent that many people may be at increased risk of fracture, so something that we are definitely concerned about. In this meta-analysis, there were similar effects in men versus women, and other studies have shown that there's increased fracture risk at the spine, humerus, ankle, foot, and fractures overall in general. So now that we know that there's an increased risk in fracture, what are the factors responsible for this? And normally we think about traditional risk factors, but interestingly, they do not seem to fully explain this increased fracture risk. Type 2 diabetes is definitely a state that's associated with increased risk of falls for multiple reasons, such as hypoglycemia, visual impairment, peripheral and autonomic neuropathy, foot ulcerations, and amputations. But this increased fracture risk persists after adjustment for falls. So it's not just falls, there seems to be a problem with the skeleton itself. And so when we think about skeletal health, we often think of bone mineral density, but interestingly, people with type 2 diabetes have normal or sometimes even higher bone mineral density, which is likely higher due to higher BMI, yet that fracture risk is still increased. And DEXA BMD scores seem to underestimate fracture risk. So if it's not these traditional factors, what else could it be? And so if we think from a schematic perspective, fractures happen because there are falls and you have impaired bone strength, and bone strength is made of bone mass and bone quality. And in type 2 diabetes, we know that fall risk is increased and the bone strength is impaired. And because bone mass or bone mineral density is normal or elevated, it seems like the bone quality is affected in type 2 diabetes. And so I'll briefly talk a little bit more about that. How is bone quality? In type 2 diabetes, it seems to be impaired by having lower bone turnover, impaired microarchitecture, and weakened material properties. This figure discussing lower bone turnover markers is adapted from a meta-analysis of people with diabetes. And so the two bone turnover markers are showed here, CTX, a bone resorption marker, and P1NP, a bone formation marker. And in this meta-analysis, you can see both markers are decreased in people with diabetes. And this is in contrast to other conditions such as postmenopausal osteoporosis, where bone turnover markers are elevated. So diabetes seems to be a state of low bone turnover. And in particular, the bone formation marker, P1NP, and other bone formation markers seem to be affected. And we also see this with histomorphometric studies that bone formation is impaired, although as a caveat, there are very few of those studies, and those few studies have just a few participants, so not a plethora of data. That's the bone turnover markers. For imaging, it appears that there's impaired microarchitecture in people with type 2 diabetes. These scans use high-resolution peripheral quantitative computed tomography, or HRPQCT, which gives detailed in vivo characterization of bone microarchitecture and bone strength. This figure was taken from a paper published by our colleagues at UCSF that looked at postmenopausal women with type 2 diabetes. And you can see here in the control, these are older women, so they probably have some baseline cortical porosity, but in type 2 diabetes, that cortical porosity is increased. So with type 2 diabetes, impaired microarchitecture, and particularly it seems to affect the cortex. And then also with type 2 diabetes, there appears to be weakened bone material strength. This has been measured by microindentation, which is a method where the probe is applied to the skin overlying the tibia and creates this tiny micro fracture. And that tells us about the strength of the material property. And so in this study here, the material strength is lower in type 2 diabetes compared to controls. And not quite, we're still trying to figure out why that is. Some people have proposed perhaps advanced glycation end products, or HEEs, which are present in diabetes, are accumulated in the collagen, and that affects the material strength. Now, going back to the clinical realm, now that we know that bone quality is impaired and bone mineral density is normal, are there other ways that we can better estimate fracture risk? This graph here reiterates how bone mineral density underestimates fracture risk. This is from a meta-analysis from JAMA. And so you can see here in people without diabetes, if you look at a T-score, say of -2, people without diabetes here in the darker line will have a lower fracture risk, whereas people with diabetes, whether on or off insulin, they'll have a higher fracture risk at the same score. And so what people have suggested are using alternate measures or adjustments, such as measures of bone quality. People have suggested using trabecular bone score, or TBS, which is given from DEXA and a measure of bone quality, or doing something like a T-score adjustment. And here in this, and here in this figure, the lines are just drawn differently. And so you can see, you can see how if you shift, like somebody with diabetes who has a T-score of -2, they can have their fracture risk can be more accurately assessed by just shifting it by 0.5. So they may have a fracture risk closer to something like a T-score of -2.5. And so I'll briefly talk about an interesting paper that tested various FRAX adjustments to see if type 2 diabetes risk could be more accurately assessed. So this paper looked at the Manitoba BMD registry and analyzed it to see if they can improve fracture risk assessment in people with type 2 diabetes. They tested 4 different methods by putting in a rheumatoid arthritis adjustment, just selecting that button, by entering the trabecular bone score, by lowering the T-score by 0.5 standard deviations, and by increasing the age by 10 years. This figure is from the paper that looks at major osteoporotic fracture and hip fracture. And so on the x-axis, having a lower score is better. It means the model is more accurate. And a good model will attenuate the diabetes effect, and it will be no longer significant. So example, for a major osteoporotic fracture, if you don't adjust the FRAX, then the diabetes effect is there. But with all the adjustments, you see an improvement in the model prediction. Although for TBS, the diabetes effect was not completely attenuated. Similarly, for hip fracture, all the adjustments improved, although lowering the T-score and increasing the age seemed to work the best. An important thing to note, none of the models were perfect. So for example, people who had diabetes duration greater than 10 years, none of the adjustments completely attenuated the diabetes effect. So while no model is perfect, one of the takeaways that I took from the paper was there is some evidence that you can make these adjustments, such as lowering the T-score by 0.5 or increasing the age for 10 years, and that would be effective for both major osteoporotic fracture and for hip fracture. All right, so moving on to back to the clinical realm and management. So one question that comes up is, are osteoporosis medications effective in people with type 2 diabetes? And since diabetes is associated as a state of low bone turnover, some people worry that anti-resorptive medications may not be effective. And so there are some studies that have addressed this, and luckily anti-resorptive medications do appear to be equally effective in people with diabetes. The drugs that specifically have been looked at are alendronate, risedronate, denosumab, and raloxifene. There are some caveats though. These are all, majority of these are post hoc analyses, and the randomized control trials just mainly look at BMD outcomes. There are some observational studies that look at fracture outcomes. And this figure is an example, a post hoc analysis from the fracture intervention trial of alendronate. And you can see here that this is looking at change in total hip bone mineral density. Subjects who received alendronate, whether or not they had no diabetes or diabetes, they had improvements in bone mineral density compared to the placebo groups. And just as a reminder, the diabetes groups tend to be smaller, so these are smaller groups. So that's anti-resorptives. For anabolic therapy, there theoretically is some excitement that since this is a low bone turnover state, maybe perhaps anabolics will work particularly well. There is one study that gives some data for this question. In the active study, they looked at the effects of abaloparatide and teriparatide versus placebo in people with osteoporosis. And in this study, they saw comparable BMD increases at the hip and spine. Unfortunately, there were too few fracture events in subjects with type 2 diabetes to draw conclusions about differential effects. And just a note, there are no head-to-head studies of anabolic versus anti-resorptive use in people with type 2 diabetes. But here's a figure from the active study, again, a post-hoc analysis. This is looking at changes at the total hip, and just in people with type 2 diabetes, so the numbers are smaller, but you can see here people who received anabolic therapy, including abaloparatide and teriparatide, had improvements in BMD compared to the placebo group. And I've just shown you the figure for the total hip since our patient had a hip fracture, but in general with anabolic therapy, those BMD increases are greater at the spine. It's like 6 or 7%. Now, circling back to our case management, just to summarize, these are the questions that I posed in the beginning. So is type 2 diabetes a risk factor for fracture? Yes, due to impaired bone quality and increased falls. Can estimates of fracture risk be adjusted for type 2 diabetes? There's some evidence that you could consider lowering the T-score by 0.5 or by adding 10 years to the age in the FRAX calculator. And are osteoporosis medications effective in people with type 2 diabetes? Likely yes, although the studies are mostly small and mainly post-hoc analyses. To go back to our case, our patient was discharged to a skilled nursing facility for rehabilitation. We ordered a repeat bone density scan, which is pending due to COVID restrictions. We recommended treatment with abaloparatide for 2 years. And our reasoning for that was, as I showed up in the previous slide, anti-resorptive therapy probably would have been fine and seems effective in people with type 2 diabetes. This particular patient had a borderline estimated GFR for bisphosphonates. We did talk about potentially using denosumab in him, but overall we suspected this patient had a low bone formation state. He had diabetes, he was a smoker, his PTH was not elevated despite his CKD. And so we thought he might particularly benefit from an anabolic therapy. And he is, of course, at high risk for future fracture, given his hip fracture and his vertebral fracture. And abaloparatide may result in greater cortical BMD increases and less hypercalcemia than teriparatide. So those were our thought processes for making that treatment recommendation. And in general, other recommendations, we recommended that he continue his cholecalciferol supplementation, encourage good calcium intake, optimize fall prevention strategies, and encourage good glycemic control. All right, thank you. So that concludes my case. Let me stop sharing my screen, and I believe we'll go into the Q&A session.
Well, thank you so much for this beautiful presentation discussing all, difficulties considering diabetes and the problems that evolve in diabetes patients with their skeleton. We get some questions through the question and answer function. People can also raise their hand. So I'll start with the first question. You just talked about denosumab. And there's the question, what would you suggest by using Prolia? Would you advise or would you advise against? And I can consider, I can add to that my personal question, what would you advise if, for example, this person lived in Europe or in the Netherlands, where abaloparatide is not yet allowed to prescribe?
Yeah, I don't think much like clinical medicine, there's not just one answer, and there are multiple options. That is something that we discussed, denosumab as a treatment option. There was a paper recently published in Bone that looked at the Freedom trial and looked at people with and without diabetes to see if they had similar improvements, and they did have similar improvements in bone mineral density. So that's kind of some nice data to support that. So yeah, denosumab is perfectly fine to use. And if abaloparatide is not available, then it would be reasonable to use teriparatide or again an anti-resorptive. So I think you have a lot of options. But just overall, just interesting that with diabetes, it's just another thing to think about. So if you have a patient that might have particularly bad osteoporosis, like multiple vertebral compression fractures, or perhaps other reasons for having a low bone formation state, just something to consider.
Thank you. Then there is another question, whether the duration of the abaloparatide and the fact that it was prescribed for men, like, did you consider prescribing 18 months rather than 2 years?
So this is Anne. It looks to me like that question may be addressing the two different aspects. One being, is abaloparatide, would you use abaloparatide in a man even though it is not FDA approved for use in men, only postmenopausal osteoporosis, in contrast to teriparatide, which is approved for postmenopausal osteoporosis, and then also for men with low bone mass. And then maybe also what the advice would be about duration. Tiffany, do you want to speak to either of those? Yeah.
Yeah, for duration, with the FDA, they limit us to 2 years, and so there are some cases where we go longer, but we generally try and stick to that. So I think I would just stick with the full 2 years so you could get the maximal benefit.
And I'll add, with respect to the men versus women question, so it is true that use in men of abaloparatide is off-label. Tiffany and I practice at the San Francisco VA care system where we do a lot of osteoporosis, and we do very readily use abaloparatide and teriparatide interchangeably when we're looking for an anabolic agent. Mm-hmm.
I just see there's no people raising hands, which is allowed as well. Then there is a question, could you comment on TBS in patients with type 2 diabetes?
Yeah, TBS is interesting, and since it's a marker of bone quality, I think people have been really interested about using it in the setting of type 2 diabetes. In diabetes, there are papers that have shown that TBS scores are lower, and even with having like the same or similar amounts of bone mineral density. So it is a nice adjunctive way of assessing skeletal health in diabetes. There is, with the impaired microarchitecture, it seems like with the HRP-QCT scans, it seems like the cortical microarchitecture is more effective, but the trabecular microarchitecture seems to be affected as well. So yeah, to summarize, yeah, TBS seems to be something helpful that people use in diabetes.
There's one more, sorry. There's also a question, is there an additive risk of bone fracture in postmenopausal women with type 2 diabetes?
So perhaps that question is focused specifically on the postmenopausal woman category, as opposed to across all patients, as was displayed in the meta-analysis that you showed, Tiffany. Mm-hmm.
Yeah, so the increased fracture risk is definitely in women and in men. So you see that effect in women as well. Whether it's an additive factor, I'm not quite sure. There was an interesting study from our colleagues here at UCSF where they did, that HRP-QCT imaging in postmenopausal women without diabetes, with diabetes, and then people who have had history of a fracture. And you kind of see along that route, like each stage, but every risk factor you add on, things do get worse. So I guess I do think of it as a, yeah, I'm sure, I would imagine that they're kind of additive, but I'm not sure there's any specific study looking at that. And do you have any other thoughts?
Yeah, there's also a live question. Anna Neiman, I will allow you to talk, then you can ask your question. I don't hear anything, is it? Yeah. We can't hear you. Okay, can you, well, I think this, well, unfortunately, I think this does not work, although it says that you're allowed to speak now. Maybe you can type your question. And then we can maybe address 2 more questions, since then we will go over to the other presentation. There is a question: what further work is needed to incorporate the type 2 diabetes mellitus button into the FREX score?
In general, I'm not aware of any. I'm not aware of any efforts to put in that type 2 diabetes button, but you know, maybe someone is working on that I don't know of. It would be great to have it, just since so many people have type 2 diabetes. So unfortunately, we don't have that now, and what the data I've presented is kind of the best that we can do at this point. But it would be great to have it.
There are many more questions left, also about histology and again, how to treat patients, but I think we need to go on with the next presentation. I would like to thank you very much, and I'll give the word to Sabs again.
Thank you for that, Elizabeth. Thank you, Dr. Schafer and Dr. Kim. We might, with some of these questions, we'll invite you again at the end if we have time, and then we will have a combined session with everybody to answer these questions. I would now like to introduce our second set of speakers, all the way from University Campus Bio-Medico in Rome, Italy. We have the privilege of hearing from Dr. Andrea Palermo and Dr. Gaia Tabacco. Dr. Palermo is an endocrinologist and clinician researcher from the University of Campus Bio-Medico in Rome, and Dr. Tabacco is a fellow at the same institute. This session will be moderated by Dr. Elena Zurdi from Dresden University of Technology in Germany. Dr. Palermo and Dr. Tabacco, welcome. I'd like to invite you to share your slides now and begin your presentation.
Oh, thank you. Thank you so much. First of all, I want to thank ASBMR for this great opportunity for me and for Gaia. We are very honored. But now it's time to talk about relationship between diabetes, bone, and in particular, the anti-diabetic treatment. Because think about this situation as usual. You are in your outpatient clinic. In front of you, you are with a patient with a bad glycemic control. So of course you have to change his or her diabetic treatment, right? And for sure, as diabetologists, you have to think about the chronic complication, the risk of hypoglycemia, and many stuff to think about. But I have a question for all of you. Have you ever thought that your choice, the type of anti-diabetic treatment could affect the risk of fracture of your patient? So it's a great pleasure to introduce you Gaia Tabacco, and she's going to talk about this topic. Thank you.
Thank you. So let's start talking about our 65-year-old Caucasian woman with type 2 diabetes complicated by severe osteoporosis. The history of diabetes started in 2012, and our patient referred that she has good glycemic control over the year with a mean A1C level between 6.5 and 7%. She has been treated with metformin for the past 6 years. The history of osteoporosis started in 2017 when, during some screening for low back pain, she discovered 2 vertebral fractures. So she started treatment with alendronate and cholecalciferol. The ongoing medication are the metformin, 1 gram twice a day, a statin, alendronate once a week, cholecalciferol 1,000 units daily, and calcium carbonate 500 milligram per day. Her weight was 79 kilogram, and she lost 5 centimeters due to the vertebral fracture, but the spine examination was negative for pain. The family history was positive for osteoporosis and diabetes, and when we estimated the calcium intake was low as 800 microgram per day, that's why she is on calcium carbonate daily. Her lab showed an A1C level of 8.2%, while calcium, phosphate, creatinine, vitamin D, cholesterol, and urinary calcium were in the normal range. The glycemic control showed a high glucose level both before meals and after meals, while the DEXA examination showed an improvement in the T-score at both lumbar and hip after 2 years of alendronate. So now we should take care of this glycemic control, and we need to change the treatment. When we talk about diabetes, we have a lot of options. We are talking about 9 different classes of drug that can also be combined one to another, improving the therapeutic option for our patient. But what is important to take in mind is what Tiffany have already shown, that there is a link between hyperglycemia and bone, and that diabetes in different ways affect the bone health. So when we think about anti-diabetic drugs, there could be also a relationship between anti-diabetic drugs and bone. And if it's so, there is an anti-diabetic drugs that is better in patients with impaired bone health. To try to answer to this question, I'm going to show some evidence, but it's important to know that most of the study that I will show were not focused on bone health, and the primary endpoint was the glycemic control, and often the falls were reported by the patient or as an adverse event. Starting with the first-line treatment, in vitro study with metformin have shown that this drug is able to improve the osteoblast activity, stimulating osteoblast differentiation, and also increasing the osteocalcin level. On the other hand, metformin is able to decrease the osteoclast activity by reducing the Rankel levels and increasing the osteoprotegerin 1. That's in the in vivo study shown a protective role of metformin on the fracture risk. So thinking about our patient that it's already with metformin, there is a green light for this treatment in this case. Moving to another class of drug, the TZD, the situation is different. Indeed, TZD are able to activate the PPR gum, and this led into the bone in a reduction of the activity and survival of the osteoblast, and on the other hand, an activation of the osteoclast activity. That's why most of the study on TZD have showed that postmenopausal women in postmenopausal women, this treatment is associated with bone loss at both femoral neck and lumbar spine, while in men, this effect is not seen. And this also led to an increase of the fracture risk in postmenopausal women that is that is particularly true in women that are on long treatment with this drug, while in men it seems to be no effect. And also when we stop this drug, there is no gain of the BMD after 1 year of withdrawal. So thinking about our patient that is postmenopausal with severe osteoporosis, probably this is not the best choice. And also the sulfonylurea, for similar reason, is not a good choice because it is associated with an increased risk of fracture, probably due to the increased risk of hypoglycemia and so the risk of falls. And when it's compared with metformin, sulfonylureas are associated with an increased risk of fracture by 25%, while the risk is similar to the TZD. So as the TZD, this is not a good choice. Moving to a different class of drug, talking about incretins and DPP-4 inhibitors, both GLP-1 and DPP-4 in bone are able to increase the osteoblast activity and decrease the osteoclast. And when we look at the studies in human, actually the DPP-4 showed a neutral effect on the risk of fracture, while the GLP-1 are associated with a protective role, a decreasing risk of vertebral fracture. And this meta-analysis takes in account all the GLP-1 that are available, but the reduction of fracture risk is particularly related to two drugs, namely liraglutide and lixisenatide, while the other drugs are associated with a neutral effect on fracture risk. Whatever, for both these class of drugs, I will put a green light when we think about the bone health. And now moving to the youngest class of drugs that are available for the treatment of diabetes, the SGLT2 inhibitors. When we first start to manage this drug, some concerns arises because canagliflozin at the beginning seemed to be associated with an increased risk of fracture. When we look after at the old studies that include canagliflozin, this association was not so strong. Indeed, only one study, the CANVAS study, was associated with a real increase of fracture. So probably there is something with the population of the CANVAS study that may have higher risk of fracture and have been driven these results. Indeed, for example, population of CANVAS study were older and with more diabetic complication. In fact, the latest evidence did not show an association between the use of SGLT2 and an increased risk of fracture. And this is true for all the drugs, dapagliflozin, canagliflozin, empagliflozin, and ertugliflozin. It is important to underline that the risk of fracture is often associated with the long-term exposure to a drug. So to confirm this result, we need more long-term detailed data. That's why on this class of drug, for now, I will put a question mark about bone health. And now talking the latest class of drug, the insulin, it is not easy to understand why an hormone, the insulin that shows an anabolic effect of bone is actually associated with an increased risk of fracture. This can be due to the risk of hypoglycemia and falls that the insulin can determine, but also because insulin is often the choice for that patient that shows some of diabetic complication. First of all, the CKD, that is per se an increased risk of fracture. But whatever the case, the use of insulin is associated with an increased risk of fracture, and the risk is reduced if we stop the insulin after only 6 months. Indeed, the recent users and the past users did not show an increased risk of fracture. So also insulin is not a good choice in a patient with osteoporosis and diabetes. So coming back to the clinical round, we need to choose a treatment for our patient with severe osteoporosis and A1C of 8.2. And coming back and look all together the choices that we have, if you take in account not only the glycemic control, that of course is really important, but also the bone health and the weight of our patient that was overweight, probably one of the best choice is the use of incretins. And before asking for your question, I would like to thank all my group in Rome, in particular Andrea Palermo that is here with me, and Nicola Napoli. And thank you.
Thank you very much, Gaia and Andrea, for this tour de force into anti-diabetic drugs and how they have the different interactions and can also have a very big impact in also our diabetic patients. I also especially like the fact that you went also into mechanistic information about how they also have their impact on bone mass and bone health. I would also like to invite everyone to write their questions into the chat and also raise their hands if they have some questions. And if I might start, we heard before from Dr. Kim and Dr. Schafer about algorithms, and I was wondering, how do you, or how would you implement and include these actions of the anti-diabetic drugs that you so well explained to us into algorithms in order to have your decision about which then medication to use?
Thank you. So I think that it's really important to look our patient from the bone status. I mean, to try to estimate what is the risk of fracture for our patient. And so if it's a high risk of fracture, for example, it is in particular important to look at the bone status of patients with long-term diabetes, or that maybe have been treatment for long time with some of the drug that I've showed that can determine bone loss, like TZD. It's important to check the bone status, and then if there is increased risk of fracture, we need to put this information in the anti-diabetic choice.
Thank you. Another question that we just got is about hyperinsulinemia per se. So also not only about established diabetes, but also pre-diabetes. And if it is a risk factor per se, how would you address that?
So it is not easy when we talk about diabetes and bone, and an example is, for example, the insulin itself, that, as I said, it's an anabolic effect on bone. So estimate the real risk of hyperinsulinemia in the bone and in bone health is not so easy. And I lost the question.
if I can add something, what I think, Elena, is that first of all, it's really hard and challenging to define a patient with an insulin resistance syndrome, first of all. And we have a huge difference from the preclinical findings compared to the clinical data. So Gaia said that it's really hard to estimate the real risk of fracture in patients with hyperinsulinemia, because you know that hyperinsulinemia should improve the anabolic phase, but in real clinical life is completely different. And first of all, we have a lot of cross-sectional data regarding this topic, but it's really hard to comment on cross-sectional data. So this is our thought.
Yes, I agree with your point, Andrea. I think insulin per se is very difficult to define, also taking into consideration then the differences between type 1 diabetes mellitus, which we didn't address to so much, and type 2, because it seems that both the lack of insulin and also the presence of insulin resistance are per se then linked to a high fracture risk. So I think this is also to the point. Yeah. Another question that we got is also delving into the fact of diabetes mellitus and the low bone turnover disease, which was also so well highlighted by Dr. Kim. And these patients with diabetes then also get CKD, and then in terms of a secondary hyperparathyroidism, also have a high bone turnover state. So how do you think that these two different entities interact with each other? Would you like to comment on this? It's a very difficult and tricky question.
Yeah, I think that's an interesting, definitely a good point. I wish that they would kind of cancel each other out. That maybe it would bring up but I'm sure it's more of an additive thing. I'm not aware of any particular studies that have looked at it, but I'm sure the diabetes won't help and the CKD won't help. So I would imagine that they would both not be good for the bone.
Okay.
And particularly studies of type 1 diabetes have shown that individuals with type 1 diabetes who have a diabetes complication, any microvascular complication, do have a particularly increased risk of skeletal fragility. There have not been studies that are large enough and characterize well enough those microvascular complications to really tease apart, is it something about the complications themselves, which may include nephropathy, or are the complications just markers of worse glycemic control or other more metabolic problems. And yet I do think it's very compelling that if a person has both diabetes, type 1 or type 2, and CKD, metabolic bone disease, that the effects of the diabetes may particularly affect the already vulnerable CKD, MBD skeleton, or vice versa. So we definitely need more research in that area.
Yes, I agree. Another question we got, which is kind of flipping Andrea's and Gaia's presentation on its back, is whether there's any evidence that anti-resorptive or anabolic bone medications per se have effects then on their diabetes and its glycemic control.
Very good question. So I know that there is a post-hoc analysis of the Freedom trial that look at the fasting glucose level in subject receiving denosumab. And there were a slightly decrease of the fasting glucose in patients with pre-diabetes, so with the hyperinsulinemia. I'm not aware of other study, Andrea.
Mm-hmm. And we have some preclinical data, old one, in mouse treated with teriparatide, I remember, with an improvement of insulin sensitivity, but just preclinical data.
Yes, this is exactly as you say, and also as Gaia said, there is also this preclinical analog to the Freedom study, and this is the work of Nicolas Bonnet and colleagues from the Ferrari group, and they have also treated then mice with denosumab and looked into their glycemic control, and they have had very comparable data to the human data. So I think it complements itself very well. Yes. Yes. Then we have another question about duration of treatment, coming also mostly about treatment with anti-resorptive drugs. And our colleagues ask since we say that it's primarily a situation of low bone turnover, would you then limit the duration of treatment with anti-resorptives, or would you be more cautious?
Yeah, unfortunately, we don't have any data to answer this question. So I think, given the lack of data, I would, if I decided to treat them with the anti-resorptive, I probably would just do the same amount of duration. But given the diabetes, keep a closer eye on them, and if there's some reason that makes me want to shorten it, then I would use that as a consideration.
Okay, thank you. then maybe coming back into the question about the histomorphometry data, because we didn't get the chance to answer this during the first half of the presentation. I don't know if Tiffany, you wanted also to comment on this. It was mostly, I think, a question about histomorphometry data per se, if there are a lot of data on diabetic patients and what conclusions can we draw out of this?
Yeah.
Yeah.
Go ahead, Anne.
Well, we wish there were more data, but very few histomorphometric data looking at type 2 or type 1 diabetes. The largest published study that I'm aware of with bone biopsies and type 1 diabetes had 18 people with type 1 diabetes and 18 matched controls, and did not show a difference between those, although to my knowledge, in type 2 diabetes, I'm aware that a paper published by Michela Rubin's group in 2012 looked at bone turnover with several methodologies, including looking at circulating osteoprogenitor cells. But they published histomorphometric data from, I believe, 9 people with type 2 diabetes and controls, and did show reductions in bone formation indices among the people with type 2 diabetes. So type 2 diabetes, it has been shown that there's a reduction in bone formation by histomorphometry. Type 1, to my knowledge, it has not, but is suspected. And the big takeaway is just how little data there are looking at tetracycline labeled bone biopsies in this group.
Okay, thank you very much for this. We also have Dr. Oy. She would also like to ask a question on, she has raised her hand. Lynn, can you hear us and can you speak?
Yes, thank you, Elena. Can you hear
Very
me
good.
well?
Yeah.
Yeah,
Nice.
so I'd like to compliment both speakers. And my discussion point is about the second presentation. I really loved your overview, which was very systematic on all the diabetic agents. And I agree that it's very appealing to look further into the incretins, as there's recent evidence that in spite of the weight loss that these people have, they don't lose bone mineral density. Just that we are lacking fracture data. And it's a bit of a difficult question, and it's more hypothetical, but how do you feel we could advance our field? How could we collect fracture data on the incretin users, which then could show that this might be a neutral or even a positive agent for fracture outcomes? So for the incretins.
So the question is how we can. So first of all, I was glad to looking at all this data, and was happy to see that the latest paper were more focused on bone health. So I think that all the community is more focused on this problem. And I think that is really important to focus the attention on long-term bone health in patients on incretins. This is particularly true for liraglutide, because the studies to now have shown that is the one that showed a protective role, since liraglutide is 97% similar to the native GLP-1. So probably the key is really the drug, the GLP-1 itself, more than all the other effects that the incretins are able to do, like the glycemic control, the control of insulinemia, and whatever.
So, Linda,
yes, so you refer to the Danish colleagues' paper, probably, which was a placebo-controlled trial for liraglutide versus placebo, which looked into bone mineral density and bone turnover markers, but was not able, as it was not powered for fracture outcomes. So I'm wondering if that would still be a possibility to look into fracture outcomes, or should we look more into more basal studies to look into the mechanism?
So I think that it's important also to understand the mechanism, but what I think is that there is a great difference between in vitro study and in vivo study, particularly on diabetes, probably because it's so complicated and multi-step disease and affects so different organisms that also the human study are really important. So
yes.
So Ling, thank you so much for
thanks
your
for
question.
sharing your thoughts.
And thank you. It's a pleasure to hear from you. But you know exactly that, in my opinion, it's really hard to collect this kind of data. And I don't think it's so easy to, I agree, to design an RSTT study aimed to evaluate this topic. Probably we can collect some data from real world data because a lot of patients are using this kind of drug. The main problem is to adjust the risk of fracture and the presence of fracture for many different confounders. This is what I think. Because of the chronic complication of diabetes, because of the other drugs, because we are talking about subjects treated with at least 6 or 7 different types of drugs that can affect the risk of falls, for instance. So it's really complicated. So first of all, first trouble is money to design this kind of study. Secondly, the confounders that are a lot. So probably the real world data and study are the answer just to better understand this topic. This is just my thought.
Okay, thank you. Gaia and Andrea. I think we're now reaching the end of our webinar. I wanted to thank every one of the excellent speakers for the talks and also for the possibility to discuss so lively. I would like to also hand over to Dr. Ramschat, who will have a closing remark for this webinar. Thank you.
Thank you, Elena. So on behalf of ASBMR, I'd like to once again thank all our speakers for their extremely insightful talks, which have generated great discussion. So thank you to the audience for your participation. As a save the date, our next session will be held on September the 1st, where we'll be hearing from Dr. Wine and Dr. Stamu on calcium disorders, and Dr. Cohen-Salal and Dr. Funk-Brentano on chronic kidney disease and bone health. You can register for this workshop at asbmr.org. And with that, I'd like to close the session by wishing you all a wonderful rest of the week, and thank you for joining us today.